Good day, everyone. I am tasked to lecture to you Biopsychosocial Approach to Care as an introduction to patient-centered care. So the objectives of this lecture are: 1. Discuss core concepts of biopsychosocial approach as it relates to the kind of care in family practice. Second, to discuss the integration of biopsychosocial approach in actual patient care using the Pfc Matrix. And last, the impact of using the holistic approach to promote better patient outcomes. So let's start with understanding the biopsychosocial approach in the context of family practice. So in our discipline, we utilize biopsychosocial approach in systems approach. So systems, as defined, is an entity composed of discrete parts which are connected in a way that the change in one part results in changes in all other parts. So in our context, family is a system that if there would be one among its members who would now get sick, then the function of that member or the role of that member will be assumed by another member. So there would be other members who will step up to fill in the gap. So in the biopsychosocial approach, if we now utilize the systems approach, there would be triaxial diagnosis because we now understand the biological condition, the psychological, and social perspectives. Why do we need to do this? Because our patients would come to our clinic, would bring a lot of factors that may influence perspectives about a certain illness. So when you look at this patient, as graphically represented in this slide, that patient would be wearing rose tinted glasses, meaning to say, reality is not equal to what is being thought of because of several factors. One would be culture, another would be influences of others, another would be past experiences, educational background, media, health beliefs, priorities. And you know that when you see patients in your clinics, you would sometimes question why would they have to delay consultation? It is because of this. For example, health is not their priority because they don't have enough resources to sustain probably a medical treatment. For example, treatment to a chronic disease. Health beliefs. They would rather probably utilize indigenous treatments or what is readily available in their setting. So they sometimes self medicate because that is what is available. Or influences of others. For example, um, others would now advise rather than going to a health facility, would go to um, traditional treatment. So all these things would now have an effect in the health and wellness of an individual. And we know that others, aside from um, these factors, there are health systems that would also affect our um, patient's perspective, like your governance, like provision of your health financing or um, access to health services, for example. So sometimes we call this social determinants. And actually, it is really related to a biopsychosocial perspective when we consider that. So there are actually a lot of literatures talking about the importance of utilizing biopsychosocial approach in primary care. because many illnesses presented in the community setting or in the outpatient care cannot adequately be assigned to conventional disease taxonomies. And true enough, the ICD-10 would have classification of factors influencing health status and health services that not really medical. For example, lack of housing, inadequate housing, non-compliance with treatment, inadequate material resources, family disruption due to divorce or legal separation or to parent-child and estrangement or your marital relationship problems. So the ICD-10 included already these social factors or this context to put in emphasis that there's a need for us to integrate biopsychosocial approach in patient care. Now, there are a lot of disciplines embracing the same. For example, in clinical rehabilitation, uh, Wade et al. Would now put out components of the biopsychosocial model of illness, looking at pathology and impairment related to probably a musculoskeletal problem. So the pathology is what the physician would give or the label attached to a diagnosis or actual state or damage and perceived state by patients and others. And the impairment would now be based on the symptoms or the pathologic condition that the patient would have. But there would be now context that would now change the labels. For example, life goals, lifestyle, past experiences, as I previously mentioned, or financial resources. And then there would be now social context, like the local culture, what the family would prioritize, or what would the family would um, attribute to the condition related to musculoskeletal complaint, probably, or from friends or work, expectations and attitudes, and so on and so forth. So there would be a lot of changes in the interpretation of a pathologic condition because of the context, as we have mentioned. So, um, our patients would come to us because of the illness experience. And that really brings our patients to our doorsteps. Why? Because, for example, a patient would have um, palpated a particular mass in the abdomen. That patient would consult a physician because of fear that this mass might be something malignant. So the condition, the mass, would have an attendant emotional context, and we call that illness. Unfortunately, when the physician is not cognizant of this, then the patient goes out with the disease without considering the emotional context. So there is now difference between the perspective of the physician and the perspective of the patient. So what happens after that? After the consultation, if there will now be disparity, you would now encounter a lot of problems. And the most common problem that we encounter is non-compliance. So in family practice in the recent years, we have this PFC matrix. PFC is patient centered, family focused, and community oriented care. And it's placed in a matrix just be to incorporate biopsychosocial perspective in patient care in actual patient chart, because it now transforms a concept, a rhetoric into action. So I hope you have um, read the article, because that's where the context and the frameworks are discussed, and it simplified the perspective in terms of the integration. So the matrix was developed to have a tool to analyze the interplay of the components of the biopsychosocial approach to care in case or in diseases encountered in the clinic. And it also helps the physician or the healthcare team facilitate appropriate holistic management. So the PFC matrix would look like this. So on this um, column, you will have your patient-centered column, family-focused column, and community-oriented column. And in the rows, you would have your data that you have to put in different cells. And then analysis based on the data that you gather. And then from the analysis, you will have the diagnosis or conclusions or assumptions, for example, in community-oriented cell. And then last would now be the management or the intervention, depending on the diagnosis or problems identified in each of the three components. So the PFC matrix would now give you a bird's eye view of what the patient has in terms of the biopsychosocial perspective. So I'll discuss to you probably just the basic concepts of these three different parts, so that you will be oriented as you go through your training in family and community medicine. So patient-centeredness is a construct that we use in family medicine as a type of care that is closely congruent with and responsive to patients' wants, needs, and preferences. So it's not really just understanding what the patient has or understanding the context of the patient, but rather putting in the intervention, the prevention, or your um, pharmacologic treatment, your diagnostic, based or anchored on what the patient needs, what the patient, considering also what the patient wants and uh, preferences. So Stuart Moira is has put this concept in a very nice algorithm. So our patient would come to us with cues, as I have mentioned in the previous slides. And those cues pertain to either disease or illness or both. So the physician, therefore, should explore both and should not miss any of these two. So the physician would look into the physical, history, laboratory results that will now define the pathology or the disease the patient has. And also, in the interaction, the physician should be able to explore the idea, the patient, pertaining to the disease, the expectations, feelings, or effect of the disease on the function. And that would now set aside the kind of management eventually, when the physician would be able to get details or data that can be placed in the three different cells in the PFC. Now, if you now get the disease and the illness, then therefore we're able to understand the whole person, because that person who is sick, who thinks to be sick, you are able to define if really there is a pathology or there is a disease, or it is just an illness experience, or if the patient has real disease, what are the patient or illness experience. So because you understand your patient, then therefore you're able to identify the problems. You would now be able to set goals with your patient and identify the role or discuss the role of the patient and your role, or the healthcare team role in managing the condition. And you call that as finding the common ground. And then with that, because you have this kind of approach, then you will have enhanced patient doctor relationship. You're able to incorporate intentionally prevention and health promotion, because you know that this patient would be at risk, or the family would be at risk of a certain condition. And then because you are able to define the roles, the goals, and the problems, and you find the common ground, then your treatment will be realistic. And at the end, when you send the patient home, you would have mutual decision making. And the decision making is informed because everything will be covered during the consultation. So what you put in the patient-centered data would be biomedical or biological, which are relevant clinical histories, physical findings, and you add the context of psychosocial issues such as emotions attendant to the health conditions, including bioethical issues, which is often than not are being explored during a regular consultation. Because you are able to get the data, your diagnosis will be on point, then patient-centered management can now be implemented based on evidence-based practice guidelines, with now incorporation of your promotive and preventive intervention. And because context, emotions, psychosocial issues are identified, then psychoeducational intervention or interventions to change risky behaviors and non-adherence can be done. So you will be able to do your primary care counseling towards behavior change or improving patient outcomes. This counseling would now be taught to you as you progress in your training. Now let's migrate to your family focused care. So family focused care in our context is that when you see patient, you always think family. You should not separate the family from the patient. So because when you think family, it's easy for you to identify family at risk. And the family at risk, because you know you have a hunch that this patient's family is at risk, then you do your genogram that would now identify biomedical conditions, hereditary conditions, or conditions that would run in the family, not necessarily hereditary, probably because of lifestyle. So you're able to map in your genogram the risk present for the family just because you have your patient in front of you and disclose psychosocial or context. And then the family within a larger system can now be explored further to look at resources that are available for the family. So we use the scream and the echo map. And for those patients with chronic illnesses and disabilities, you're able to identify family caregivers and eventually anticipate to provide care for these caregivers to prevent fatigue. And then, because you think family, you always think that you need to work with the family members, and that you are sensitive to the fact that you might need to do family conference in the future because you want to improve patient care. You want to address the family at risk of a certain medical condition. So, what are the data that you would include in the matrix? You would now put essential data that would give you an idea of the psychodynamics of the patient. Because the psychodynamics would now either be a barrier or a resource for you. So, as I have mentioned previously in the slide, you work with family, you engage the family to be part of the therapeutic triangle and make them your ally to help in managing the index patients. So, we have tools in doing that. We look at family systems similar to what I have described early on. And then, because you understood or you have a better idea or you have a bird's eye view of the family dynamics, then you can do appropriate family intervention. It can be health education, it can be counseling, or it can be a family meeting to generate consensus, especially for important decision making like surgeries or embarking into an expensive treatment due to family meeting or family home visit, which is a very important tool that we have in family and community medicine practice, that physician can visit um, their families or their patients in their homes, and it's an opportunity also to be able to look at the setting or the condition of um, the patient in the homes. And as I've mentioned, the goal is to enable the family contribute to the care of the family member who is sick and to decrease the potential of health risk or decrease the potential of the family of the health risk. Okay, we go now to the larger system, which is a community. So community-oriented primary care is what we use in family and community medicine because we link now patient care with community health. So, in community oriented primary care, there is an integration of the clinical practice with the community health. And there would now be a link of the community into the practice. And the link is necessary to promote health and prevent disease, alleviate suffering and disability. There are a lot of value, or there is value added in doing this because, for example, your patient with dengue is discharged or you manage in your clinic and you send them back to their community where dengue is prevalent. So there should be something done in the community, and that something would be health promotion or preventive interventions. So there is a link between clinics and community health. And the link is actually providing continuity of care. The continuity of care, not only with the regular follow up, but also the link, as I have mentioned, of community health with individual health. So, what do you put in the PFC matrix for the community oriented care? So, in order to link, you should have a better understanding of the epidemiology of the disease. You should know the epidemiology of the disease. And you should able to identify the social determinants affecting the disease, because this is now the social context, as I have previously mentioned, not only factors internal to the patient and in the family, but the social or the higher system as a whole. And then the WHO health system building blocks, focusing now on the need of the index patient or the family at risk. So there are issues sometimes in looking at health systems, and it is being separated with the actual disease of patients. It's far fetched from the reality. Health systems would be higher system, and the lowest system is the individual patients, but there should be an integration, and that is what the community oriented care would like to link in, as indicated in the PFC matrix. So what would be the interventions? Examples would be care, navigation, and coordination to improve that kind of link. It can be disease-based group intervention. It can be patient support groups. It can be linked between government and non-government that would now enhance patient care or improve health services, and implementation of population-based services for health promotion that are people initiated. So, what are the outcomes of a holistic approach if we use this kind of perspectives? I've selected few studies. For example, this biopsychosocial oriented primary care provided by Family Medicine Institute in Israel. And they offer this kind of course to all general practitioners, not necessarily family physicians. And based on the study, there is actually a huge impact of biopsychosocial approach in the cost of care. There is a change before and after the intervention that they have done in terms of uh, prescribing habits of physicians, um, request of laboratory examinations, referral to other services, providing psychosocial instructions, and improving, therefore, patient satisfaction. Although, which is probably not a setback, but probably from others who would have a lot of patience, setback is because you have this kind of interaction with your patient, then the duration of your doctor patient encounter would now be longer. So, in our practice, the shortest is 15 minutes, and the longest would even probably um, more than 30, 45 to 1 hour, depending on the severity or complexity of the condition, and especially if the patient will consult in the first time. So, this study actually is a initial study that would show that biopsychosocial approach utilizing family medicine perspective decreased cost of care and improve patient satisfaction. Now, another study in terms of patient management, this is one of the conditions that we encounter in practice that are so undifferentiated, and it can mean a lot of things. And based on the study of Gatchel et al., they showed that the use of multidisciplinary biopsychosocial rehabilitation for patients with pain really improved pain control and increased a number of people return to work compared to the control. And in fact, in the Cochrane collaboration, there's a recommendation that intensive multidisciplinary biopsychosocial rehabilitation for functional restoration of patients with probably chronic pain should be done, because this kind of approach would now help your patient regain mobility and function, improve psychological conditions such as depression and anxiety attendant to chronic pain, and allows a return to normal life activities. So, in summary, biopsychosocial approach, if you use the systems perspective as we do in family practice, we have this triaxial diagnosis that would now put out the three kinds or three perspectives that would define a biopsychosocial approach to care: the biological, psychology, and social perspective. And in our context, we utilize the biopsychosocial approach to improve patient care by incorporating psychosocial factors affecting biomedical condition with emphasis on health promotion and prevention. And we have the Pfc Matrix that would actually provide objective data and approach to enhance our understanding in the biopsychosocial approach to care, so that appropriate intervention be made to improve adherence to medical care and promote better patient outcomes, as shown in the two studies that I have added in this lecture. In that the necessary and appropriate family and community interventions um, are being developed to minimize cost of care, efficient delivery of health services, and implementation of relevant health policies. So I would want to end with this. In the sick room, 10 cents worth of human understanding equals $10 worth of medical science. So if we just listen, we just change our perspective and utilize biopsychosocial approach in the way we handle our patients, then unnecessary misdiagnosis, unnecessary diagnostics, unnecessary prescriptions will be prevented. And as Patch Adams would say, if you want to become a doctor, you need to learn to treat the patient as well as the disease. If you treat a disease, you win, you lose, especially if your patient dies. But if you treat a patient, you win no matter what the outcome is. So, my dear colleagues, the biopsychosocial approach is not just rhetoric, but it is a doable approach in patient care that would now improve the cost of care, improve patient satisfaction, and most importantly, you're able to put in the context in the care of your patient.